So today I will talk something different from genomes, but I promised have you end with genomics in the end. So I will introduce our work about subtyping muscle-skeletal disease use large-scale electronic health records. So muscle-skeletal disease is a huge global growing burden based on the GDP. 2019, there is 1.7 billion people affected by the muscle-skeletal disease, and is the number one cause of disability, which accounts for 5%, 5%, over 5% of US GDP. And the research problem is the heterogeneity. Conditions actually overlap with each other, and also it overlaps with the other conditions such as the cardiovascular disease, diabetes, and other conditions. So if we broadly give the broad labels such as frozen shoulders or Dupuytren's, it actually had very different patients of their profile. So this actually gives us the intuition to look at the electronic health records data to do a subtyping work for the muscle-skeletal disease. So the disease diagnosis labels such as OA or frozen shoulders, they actually only represent broad clinical categories, but the patients, even they have the same disease, they show a lot of heterogeneous in terms of comorbidity, their disease trajectory, and we don't know what kind of healthcare which play important roles. We don't know how it can be shown if we only look at the disease label itself. On the other hand, the large-scale electronic health records, it captures the longitudinal, routinely collected clinical data at the population scale. So this actually is a very rich, beautiful data resources for us to do data-driven identification of patient subgroups within and cross disease condition. So what kind of data do we have? We have the routinely GP and hospital records in UK. And as you know, that the GP and hospital records, including the diagnosed labels, every patient's, what kind of disease they have in their life, the prescription, what kind of medicine they have taken and prescribed by the doctors, and measurements such as BMI or blood test. So these are all beautiful and valuable data informations we look at. So our main data set is what we call CPRD, which contains over 30 million of UK residents. It is the GP or primary care based information, but it's also linked with the secondary, the hospital data from 1985 to 2021. This is our primary data cohort. However, to show our EHR-based clusters that can have good generalization ability, we don't want it to be used only in this cohort only. We also choose two external validation data sites. One is UK Biobank, which has 500K of participants, and half of them are linked with GP data, and all of them are linked with hospital-based data. Another good thing is that actually we have the EHR data set. The UK Biobank provides both the EHR and the genetic information. So we can link the patient's EHR profile to the genetic and other biomarkers. Besides, we also want our clusters, the model from the subgroups can be validated in the internationally. So we choose a US data set called All of Us, which has 300,000 of participants. This is quite challenging because based on EHR, the system between UK and US is very different. In US, they don't have the GP system. Everyone needs to go to the hospital. So if our clusters, the subtypes we found can be validated on this data set, we're going to have the confidence to show the model's generalization ability. So how does the data look like? Here is an example I give you. Assuming one patient, he or she registered at GP at the beginning at the year of 37, and every time when he or she goes to GP or goes to the hospital or do a referral, here we have the diagnostic or measurement data set that encoding into, for instance, the diagnosed data, we will encoding into SNOMED code, or we encoding into the ICD-10 code. For the medication data set, we encode to the BNF code. And until here, which is the date of patients diagnosed as the musculoskeletal disease, we use all the pre-information as input and then put the sequence data into a transformer model. And the transformer model, during the transformer model, in the transformer model, we use a training strategy called contrastive learning, which we randomly cut one patient's whole EHR system before the disease diagnosed into two parts. We let the model to learn the same patient's EHR as the positive pairs, well as the one patient's first part with the other patient's second part as negative pairs. In this way, in the hidden dimension level, the model will understand how a patient disease trajectory would like, have a good representation of the EHR data, and then we apply for a K-means model to which use the learned representation of the EHR as the input and automatically generates the best K, the number of clusters for each patient. So then in the future, a new patient comes, we put into the model, and the model will generate the patients as cluster 1, 2, 3, 4, 5. But that is the label itself. What does the label means? So then we have a look about the prognostic information, whether the patients in different clusters, they will prognostice differently. We also have a look about the comorbidity, like the pre-disease. Do they have the same disease burden or not? We also have a look about the disease-specific symptoms, because we also want to verify that those clusters actually, their prognostic, their comorbidity, and disease-related symptoms differentiate from each other. So if we can verify these three, the clusters differentiate from each other in clinical practice, the last thing we want to do is that to look at whether those clusters differentiate from each other in biologically or from the gene perspective. So here is our data cohort. This is the good case by using EHR, because we have very large scale data and it is free to use. So we captured over 100K for CTS in CPRD and over 1 million OA cases in CPRD. So very large this cohort, and you can see that for all of us, although the total number of cases, they only have 300 of case, 300,000 of case, the total participants. Actually, the disease prevalence is differentiate from the UKB, which UKB have more patients, but we can see like in CTS, they have more patients, showing that actually UK and US, the disease patterns are different. So here is the how many clusters we should determine. We use a matrix called prediction strength stability criteria to check the K. And the optimal K was determined for CTS. We have 4 clusters, and for Dupuytren's, frozen shoulders, and OA, we all found 5 best clusters, and each cluster shows this actually shows the differences of the clusters. So we also want to know whether the trained model on the CPRD, we found the best clusters, whether the cluster still holds on UKB and all of us. So we just applied the model we trained on CPRD to UKB and all of us, and we can find that the cluster actually separated from each other pretty well. So since the clusters can differentiate from each other, then we have a look about what actually behind the cluster label. First, we have a look about the pre-diagnosed comorbidity. So as you can see here, the cluster 1, we found that the cluster 1 patients have a high prevalence of menopausal related disorders,
Well, in cluster 4, we found a high risk of hyperthyroid burden before the OA onset. Besides, for cluster 5, we found that there is a heavy, over 93% of patients, they have a hypertension when they diagnosed as OA. This is the pre-disease comorbidity burden. Then we have a look about the progression. Two things here we look at. First is the all-cause of mortality. Second is about the OA-caused hospitalization. As we can see that those 5 clusters, actually, their mortality rate, 5-year mortality rate and hospitalization significantly different from each other. Last but not least, we have a look about the disease-specific related symptom. Here we found cluster 1 have a higher rate of pregnancy before the disease onset. This actually aligns with what we found clinically. That's like the pregnancy women, after they give birth, they need to take care of their babies, so they're quite easy to hand related OA. So we found that from the symptom level, from the progression level, and the pre-disease burden level, those clusters all differentiate from each other in one or other way. So we also look at like disease-related, for instance, hand injury or the other things, but I won't go to very details. In summary, for the OA 5 clusters, we found cluster 1 is most of them are women, over 70% females, and high pregnancy prevalence, lowest comorbidity. Besides, we have a cluster 2, which majority actually are men, and the age is 58. So cluster 3 is pretty interesting. I call it intermediate risk because all the patients are pretty old. When patients diagnosed as OA, their average age is 71, but actually their progression, not only the mortality, but also the hospitalization rate are actually not that high, especially comparing with cluster 4, who is younger than cluster 3, but actually they have higher disease burdens. So we also apply the whole pipeline into carpal tunnel syndrome, to frozen shoulder and Dupuytren's, and we found something similar and something disease-specific. For instance, in CTIs, we found the oldest group, the cluster 5, is hypertension plus degenerative joint disease group, whereas we found the frozen shoulder, the cluster 2, it is dominated by men, and we found lifestyle factors such as smoking actually is the main feature in these clusters. Besides, we found something in common. For instance, all the cluster 1, they are young female, and they all have a history like reproductive history or have the menopausal related history. So in summary, what EHR-based subtyping reveals to us based on our model. So we found actually age is very important. The progression increase across the clusters from cluster 1 to cluster 5. And we found like the MSK disease actually have a strong stratification in all 4 MSK conditions. For instance, the cluster 1 I mentioned, and cluster 2, which is most of them are male groups. We found chronic burdens actually accumulate the risk of the patient's progression, and the productive signals also define the female-enriched clusters. So the take-home message is that EHR-based subtyping captures shared population structures across all MSK conditions, but alongside there are some disease-specific phonetic signatures. So I think we have verified the progression of the clusters. They are differentiate from each other. From the comorbidity analysis, we found like those clusters have different comorbidity burden and symptom levels also differentiate from each other. The next step, what we want to do is to look at the genetic differences, because although the current clusters can help us to, when a new patient comes, based on the pre-EHR data, we will know the patient's risk of being mortality and hospitalization, but we don't know how to treat them. If we can find one or two clusters, they are biologically differentiate from each other, then we found that there is a target treatment for those patients, maybe medication or treatment. So that is the next step we are going to do. So in our MSK clusters, some of our colleagues have already did genetic-based clustering, and we are trying to map with each other to see whether there are overlaps, that they started from genome to phenome, where we started from the phenome to genome. So yes, that's all I want to share today. I want to thank for our MSK cluster colleagues and our founders and collaborators. Last but not least, we are going to have a machine learning in functional genomics course in Oxford in the Jesus College from, I think, the late September, 21st of September to 25, and it is free for the functional genomics intuitive participants. That's all. Thank you.